Hi, welcome to tonight's VCU Health Seminar on chronic knee pain. My name is Samantha Kramer, and I'm a member of the marketing team at VCU Health. Today, we are joined by Dr. Robert Oconnell and Dr. Alexander Vapp, experts in orthopedics and sports medicine, as they discuss how to improve your quality of life through various treatment options for cartilage defects in your knee. Before we begin the presentation, I would like to first make note that we will hold all questions until the end. Please feel free to drop any questions you may have in the Facebook comment section throughout the event, and we will address them during the Q&A portion. Dr. Oconnell is an orthopedic surgeon at VCU Health and assistant professor in the VCU School of Medicine's Department of Orthopedic Surgery, specializing in sports medicine. The surgeons and residents there practice out of 5 sites across Greater Richmond, including the Level 1 Trauma Center at VCU Medical Center, caring for a wide range of injuries that are often related to athletic participation with patients at all levels of competition. Dr. Oconnell joined VCU Health after completing his residency at VCU Medical Center. He brings a background in biomedical engineering to his knowledge of complex arthroscopic procedures, which often require implantations to repair bones or replace missing joints. Dr. Alexander Vapp is also an orthopedic surgeon specializing in complex sports medicine of the knee, shoulder, and hip. Dr. Vapp received his medical degree from Wake Forest University School of Medicine, followed by orthopedic surgery training at Duke University, where he provided physician coverage for most of the university's athletic teams. He then completed a fellowship at the Stedman Philippon Research Institute in Colorado, followed by a fellowship in Norway. So thank you, Dr. Oconnell and Dr. Vapp, for joining us today. I will now turn the show over to you.
All right, I think I'm live here, Samantha. Thank you for that introduction. And as she said, my name is Dr. Oconnell, and I'm an assistant professor at VCU in the sports medicine division. Dr. Vapp and I are really excited to be able to talk to you all today about chronic knee pain that can be associated with cartilage injuries. We want to be able to give you more information to help improve your quality of life through various treatment options that we have. Management of cartilage injuries is one of the biggest and hottest topics in orthopedics right now, and there are a lot of new and exciting treatment options that we can provide to our patients. Knee pain caused by cartilage injuries can oftentimes be debilitating and devastating to a patient's quality of life, and we really want you to know that we're here to help you and have things that we can offer. So to start off, I'm going to introduce the topic of cartilage injuries, and then Dr. Vapp and I will talk about 2 more specific treatment options that we often employ for larger and symptomatic lesions. So what is cartilage? Cartilage is the smooth white tissue that covers the bones at the end of your joints. It allows for the bones to glide over each other and allows for smooth, painless range of motion with activities and weight bearing. So cartilage injuries or lesions can occur in patients of all ages. These can be traumatic or just degenerative in nature. Most commonly, we see these in the knee, but they can also present in any joint in your body. The lesions can be of various sizes. They can also be in one area or multiple areas of your joint. And one of the biggest problems with cartilage is that it lacks an intrinsic ability to heal itself, and over time, they tend to get bigger and more symptomatic. So what's the problem? I, like Dr. Vapp, like to tell patients that cartilage injuries can act like potholes in a road. And when the cartilage is intact, it's like driving on a nice newly paved road. But then as the road wears out over time or with an accident, the driving isn't so smooth anymore. So similarly, in a knee with a cartilage injury, your motion can cause significant symptoms. Patients typically will present with things like pain, recurrent swelling, stiffness, feeling like the knee is going to give out or kind of give way. And the symptoms can really hinder your ability to work, play, or even just perform everyday activities. So when you come see one of us for an evaluation of this type of problem, typical workup includes a physical exam, usually plain x-rays. Sometimes these lesions aren't obvious or seen on x-rays, and after failure of more simple treatments, an MRI can be indicated to help diagnose a clinical cartilage injury. And you can see on this right image, this area of swelling and cartilage injury on a knee. Occasionally we get special x-rays to evaluate what we call leg alignment, which is to see if you're either knock-kneed or bow-legged, to see if you have excessive pressure being placed on either the inside or the outside part of your knee. So once a cartilage injury or lesion is diagnosed, the treatment's dependent on a lot of different factors, which can include the size of the lesion, the location, which would be what bone and where in the bone, the age of the patient, and really importantly, the activity levels and goals of the patient, and also other lesions or concomitant issues in the knee that need to be addressed. So these are typically things like your alignment, ligament status, so like an ACL injury or other ligaments inside your knee, or the status of your meniscus. Like I said before, we typically try non-surgical treatment options first, which are rest, ice, elevation, activity modification. Sometimes we do bracing. We use multiple types of different injections, which would be like steroid injections or a gel injection called hyaluronic acid. And then more recently, we have what's called biologic injections, which would be like a PRP injection or a stem cell injection, which can help theoretically regenerate cartilage and prevent further damage. So, once we diagnose this, then we go through this treatment algorithm. So with small lesions in a low demand patient, so without high activity levels, sometimes a simple debridement or a cleanup of the injury through a scope, which is a minimally invasive procedure, can provide short-term symptomatic relief. It can reduce inflammation, but there's limited regenerative potential and the long-term success rate is unpredictable. With more active patients or with bigger lesions but are still less than 4 centimeters, we typically need to employ some more advanced techniques, which would be either a marrow stimulation procedure or what's called an osteochondral autograft transfer. A marrow stimulation is where we poke holes in the bone to stimulate bleeding into the lesion, which allows for stem cells and other factors in your blood to coat the lesion and assist in growing your own cartilage back into that area. And you can see a picture up here in the top right of the screen showing that. An osteochondral autograft transfer is where you take a piece of healthy bone and cartilage from another area of your knee and transplant it into the pothole or defect into your knee, which can be successful for small lesions. However, there are potential side effects, including donor site morbidity, and the biggest one is probably the limitations in how big of a lesion you can treat with this. So while those are good options for small lesions or in lower demand patients, what happens, if you have a bigger lesion or you're really active or you failed to respond to some of these more simple procedures? That's where these other two procedures, one is an osteochondral allograft transplant, or an OCA, or a matrix-assisted autologous chondrocyte implant, or Macy, so we don't have to say that so many times from now on, come into play. And Dr. Vapp is going to focus on the Macy procedure, where your own cartilage cells are harvested, grown in a lab, and then put back into your knee. But I'm going to focus on the osteochondral allograft transfers. So this is a procedure where you take a plug of cartilage and bone from a cadaver tissue. It's a fresh cadaver graft, and we match it perfectly to the pothole defect in your knee. An open incision is usually used, and special instruments are used to kind of create a perfect press fit match for this donor plug to go into your knee. And it refills the injury in with live cartilage cells. So this is a picture of an actual knee that this is done in. There's 2 lesions treated with this. And you can see that the donor plugs are put into the knee, and that's the new shiny white areas. And they fit in and typically don't require any sort of screws or hardwares to hold them into place, which is also a benefit to this. This procedure is ideally suited for larger lesions with underlying bone involvement and in highly active patients. So what to expect after this procedure is a lot of times this can be done as an outpatient, but if you have other concomitant injuries to the knee that need to be addressed, like an alignment issue or ligament injury or meniscus injury, sometimes when we do that much surgery, it requires a stay in the hospital, but not frequently. A lot of times almost all the time, you're in a brace after surgery with an ice machine on, and this is typically what the brace looks like. You're on crutches with non-weight bearing status for about 6 weeks with the goal to return to full weight bearing by 8 weeks, and you start physical therapy right away. Now, the return to high-level activities is usually about 9 months, and here is a typical PT protocol that we use after a surgery like this. And here at the bottom, you can see that we usually advance functional activity to sport-specific activities around 8 months, and that's just to limit the high impact that you have on the graft. But it's not that long before you're getting back to doing more normal activities and low impact stuff. As you can see here, is like elliptical, bike, and pool activities can start as early as 3 months, depending on symptom levels. So my indications for doing osteochondral allograft for someone with a painful cartilage defect on a weight-bearing surface of your knee, and someone that has a desire to return to high-level activity, usually between the age 18 and 55. You need to be able to perform the rehab and be able to attend regular PT visits, usually about twice a week. And we have to either address other coexistent lesions at the time of surgery or before the procedure, because it can increase your risk for failure. Looking at the pros of the procedure, it's a single stage procedure that preserves live cartilage cells. There's no donor site morbidity. The literature has shown that it's very successful for lesions bigger than 2 centimeters. But some of the cons are that the grafts are sometimes limited because we have to get a fresh graft from a cadaver. These are associated with high cost. The graft is a living or a live allograft tissue. So there is a risk of an infection or a host response while it's very rare. The recovery can be long. I usually tell people to expect up to a year before they're feeling totally back to normal. And then the results have been shown to decrease as our age goes up, especially over age 40. This is the biggest study to date on osteochondral allograft transplants, and with almost 6-year follow-up, they have about 75% of people with their knees are able to return to recreational activity. There was a 9.4% graft failure rate, but 91% of people were satisfied with the result of the surgery, while about a quarter did require a second operation for all reasons. So in conclusion, you do have options when you have pain that is secondary to cartilage injuries in your knee. Early recognition can be key, so come in to see us as early as you can. Once you start having symptoms that we talked about, we have good techniques that can return people back to activities with good success rates. While not perfect, but it can definitely help patients. And one exciting thing is that the technology is still advancing really rapidly. This is probably one of the biggest areas of study in orthopedics. There's a lot of new graft types that are synthetic cartilage. There's more biologic injections and augmentations that we can do in the knee. But it's exciting for us to be able to provide this to patients, and hopefully in the future we have more options. So with that, I'm going to hand things over to Dr. Vapp, so he can talk specifically about the Macy procedure.
All right, thanks, Dr. Oconnell. Good evening. It's really excited to be here to be able to talk to you this evening, kind of give an insight about some of the things that Dr. O'Connell do for our patients here at VCU. So again, I'm going to be talking about autologous chondrocyte implantation, and again, the short term we usually describe as Macy. So I'm going to focus mainly in on issues underneath the kneecap in terms of cartilage damage, and this is an area that we see a lot of problems that folks come in with pain and issues from. And some of the common symptoms to recognize if you're having issues with your kneecap is going to be, pain directly over the kneecap itself. Oftentimes people notice it when they're ascending or descending stairs. Squatting down or kneeling down is quite common. A lot of times people talk about when they're getting down on the floor to play with their kids, or squatting down to pick something up, they'll notice it. Sometimes it can be associated with grinding or crunching when you're bending the knee or extending it. And sometimes you might have a history in the past of having issues with the kneecap slipping out of place, or some type of injury to the kneecap itself. Again, as Dr. O'Connell referred to, when you come in to see us, we'll do a first initial evaluation. Obviously, ask you questions about when the pain started, when do you notice it the most, what have you possibly tried in the past. At that time, we'll examine you. Some of the exam findings we look for is swelling in the knee, pain over certain parts of the kneecap, certain examination maneuvers that can help give us insight into why it might be bothering you. And oftentimes we'll then also get plain x-rays, which allow us to look at the joint space, meaning the general overall health of the knee in regards to the cartilage. If we do think you have a cartilage injury, or especially involving the kneecap, oftentimes we'll try to manage this conservatively, meaning nothing surgical, at least for probably at least 12 weeks. We'll start with rest, ice compression, and elevation, meaning just kind of get you through any early inflammatory phase. NSAIDs are a great option to take. Physical therapy also can be quite helpful. Sometimes people don't even realize they've lost a lot of strength in the leg and their hip. Some of the patients that we see this most commonly in is actually distance runners. They're quite active, in great shape, but if you don't really focus in on your core strength, sometimes that can lead to knee issues developing. And depending upon examination or what's been tried or what's helped, as Dr. O'Connell referred to some of the injection options, some of the more common things we do are corticosteroids or hyaluronic acid. Both are aimed at reducing swelling in the knee, helping with inflammation, and allowing you to kind of have more activity with it. And then biologic injections, which include things like platelet-rich plasma or bone marrow aspirate injection, which have shown some success. If you're continuing to have knee problems, the next step in my practice would be likely an MRI without contrast. An MRI is a magnetic resonance imaging that allows us to see a lot of the soft tissue inside the knee, including the cartilage. So unlike x-rays, the MRI allows us to evaluate ligaments, meniscus, and cartilage, which we don't see on the x-rays. This is a cut of an MRI looking in the axial position. So if you were looking in a cross section, and on the top there, along this upper edge, you'll see the kneecap here. And then this area right in here is where we have the cartilage. And so the cartilage on the inside part here, this nice thick gray area on the inside part, is normal healthy cartilage. And as you get over more to the outside part here, you start to see where that thins out. And that's what we're looking for when we're looking in regards to a cartilage injury. And you can see underneath the bone, as a result of that thinned out area, they're starting to get some of these what we call cystic or bone reaction or edema from that area where the cartilage is thinned. And another analogy I like to use is if you've kind of lost the shock absorption in the knee, the other parts of the knee, you're going to see a lot more stress. So what is then are we thinking about options? So if you're having an issue with the kneecap and we see on an MRI one of those defects, some of the patients we think about that this could be a good option for is based upon the size of the defect. So similar to what Dr. O'Connell was talking about with the size, whether it's full thickness, meaning it goes all the way down to the underlying bone. In general, this procedure we aim to do from age 18 to 55, so it's not necessarily everyone who's in their 20s. Important that you're able to get through the rehab after something like this, and also have realistic expectations that we're trying to, in essence, recreate a surface for you as best we can. It's a little bit hard to make it feel necessarily like you're 16 again, but definitely an improvement of what you're feeling at the time. And then obviously what your expectations. The recovery is long. It can take up to 9 months to a year, and that is a big personal commitment, both in terms of work or personal life, in terms of rehab and other things associated with the surgery. So autologous conscious site implantation, patients always ask me, well, this is amazing. I've never heard of this before. And it's actually been something around for a while. The first use of it was actually back in the 90s. And at that time, then it was in the process of getting FDA approval, which was obtained in 1997. And those early uses of ACI had some downsides to it. There were some issues with some cartilage overgrowth. A lot of patients had to have repeat surgeries and other things. There was still improvement with symptoms and pain, and there was definitely a benefit to it, but it didn't have the same reproducibility that we can see today with the current technology. And Macy itself was first approved in Europe in the early 2000s, and then once some of the results came out with the trials in the US, it was finally approved here back in 2016. And I've been using it my past 5 years in practice, and I actually used the earlier technology when I was in my training at Duke. So I've been very familiar with it, and it's a great technology that allows us to really help people. So what's the general process for the ACI or Macy procedure? First, if we've taken you through a conservative treatment and we have an MRI that shows a cartilage lesion, I would likely recommend at that time to proceed with a knee arthroscopy, so a minimally invasive procedure where we take you to the operating room, make small incisions inside your knee to look inside with a camera and allow us to better assess that cartilage injury. If once we get in there, what we have seen on the MRI correlates with what we see in the operating room, and we think that lesion's in a big enough and high enough grade and thick enough that it would possibly be a candidate or benefit from the Macy procedure, at that time I will then take a small biopsy, so a small piece of cartilage from a part of your knee that's non-weight bearing, meaning you're not using it, but the cartilage is there. And we take that piece of cartilage and place it into a specimen container with a certain solution that you see in the screen on your bottom right. And at that time, the specimen is then sent up to the storage lab up in Boston, Massachusetts, and the specimen lasts for 5 years. Okay. At that time, we then go ahead with the debridement or other procedures that to address the cartilage lesion. And then after that, we have people go through rehab or rehabilitation after the knee arthroscopy to see how they do. Oftentimes, some patients will feel a lot better after that simple debridement, as Dr. O'Connell referred to, and might not necessarily want to proceed with the Macy procedure or the second stage. And the good news is the biopsy lasts up to 5 years. So if we do that initial knee arthroscopy, you get better for a year or two, but then having worse pain down the road, it doesn't mean that we have to take you back again to the operating room. We still have the sample for up to 5 years. So once that's done, if we do end up proceeding with the second stage, we'll have them start growing the cells up in Massachusetts. It takes about 3 weeks to grow the cells themselves. And those are impregnated in onto this matrix, patch, which then is what we implant into the knee. Okay, so here's an example. So this is some images for some kneecaps that I've treated. So this is a kneecap flipped upside down. As you can see here on the picture on the left, this inside area here, that smooth white area, that's the normal cartilage. And then we have on the other side the defect. So as you can see why we kind of refer to these as potholes. And the same thing on the right side. Again, you see this area is the smooth cartilage, and in the central aspect where it's rough and almost looks like cobblestones is where you have that pothole again. When we're doing the Macy procedure, we then, in an exact fashion, using basically an incisor, clean out the rest of the damaged cartilage to make a nice clean bed. We want to make sure we have nice sharp edges all around the site of injury. And we remove all the remaining damaged cartilage right down to the subchondral bone and not farther. So you want to make sure that not to get into the bone itself. That's important for the procedure. And then once that's done, we take that same size incisor. So this is a picture from the operating room when I'm doing one of these procedures. At the bottom area, we have this incisor. That's what we use to remove the cartilage inside the body. And we use that same shape incisor to create the exact shape to match from the implant, which is right here. So this is the matrix that has the cartilage cells implanted in it. And once we've incised that, we keep it in a solution they provide, and we then take it back and implant it into the knee. And we hold it in there. I'm sure you're wondering, well, how does it stay in there? We put what's called a fibrin glue. It's like a biologic glue. We put it in the base. We put the implant in and then seal off that with the glue, and that stays in place. And then we take your knee through a range of motion to make sure that it remains intact. And it's underneath that surface. And so when we've looked at these stay nice and stable and allow the cells to start growing. Once that's in there, the whole process, in essence, is almost magical in the sense that the cells start to migrate from that membrane down. So you see in this top picture, we've put in the implant, and then it starts to migrate down. And that's how the cells kind of start to expand and fill in that cartilage defect. And over time, that pothole then disappears. Okay. To kind of give you an example of this, so these are two pictures from a college basketball player from one of the teams that we take care of. She was finishing up her career. She'd been having some anterior knee pain. We'd gotten an MRI that showed a cartilage defect, and I took her to the operating room. She had a pretty sizable pothole in that center part of the kneecap, and she was interested in continuing to play basketball, possibly professionally afterwards, and she was worried that she wasn't going to be able to as a result of that. And so we went and took her and completed the Macy, and then she had some issues with some stiffness afterwards. But when we took her back to help with that, to free up some of the scar tissue, when we looked at the Macy, you can see how literally that pothole has disappeared. So it's quite amazing when it fills in, and she's doing great. She's back to playing basketball and is obviously excited about it. But this is just one of the many stories or examples that we have of some patients that we can help with this type of procedure. And Macy works in other parts of the knee. It's not just the kneecap. I use it a lot in that area because I think it's very helpful as a resurfacing tool, but it can also be used in some of the other weight-bearing portions of the knee. And it's a great piece, tool that we have to be able to help folks with these types of cartilage lesions. Thank you.
All right. Thank you for that informative presentation, Dr. O'Connell and Dr. Vapp. We will now open the floor to any questions. Before I address the questions in the chat, I will first read a few that were submitted in advance. So number one is, if I experience a popping sensation during movement in my knee, should I seek medical care?
Yeah, I mean, it depends on if you have pain associated with that popping or if there's a traumatic injury. You know, sometimes people have popping, which is totally normal, but it becomes abnormal if you have things like pain, swelling, or difficulty doing activities when you feel that popping. You know, more along the lines of what Dr. Vapp was talking about with the kneecap, you know, sometimes you have to differentiate popping from like a dislocation event of the kneecap, which can definitely happen sometimes. So it depends, but the biggest thing is if you have pain and swelling associated with it, then I would definitely say come in and see someone.
The second question is, can cycling exercise increase or improve knee movement?
Yeah, I think that's a great question. It's definitely a good thing to be able to do, not only for cardiovascular conditioning, but it does help knee pain in a lot of ways, mainly from the exercise and strengthening it's providing. So that cycling is great for your hip strength and for your quad and hamstrings. And those are some of the things we look for in our exam when people are coming in having knee pain. And oftentimes people describe, well, I've been a runner for years, or I'm trying to do a lot of jumping or impact activities, and I'm just having too much knee pain. And at that time, a lot of times we'll recommend cycling, whether it be road cycling or stationary bike, as a less impact activity that can really help with strength. And people will notice big differences with that. So it's a big part of the rehab and a lot of our surgeries also. So I think it's a great thing to be able to do.
The third question is surgery the only option to fix knee cartilage issues?
No, I think both Dr. Vapp and I talked about other options during our talks. You know, obviously we always start with the non-surgical options, which would be the physical therapy to build your strength, work on your range of motion. Not every cartilage lesion needs surgery. There are certain, the injections can certainly be helpful. The new biologic injections have been shown to be helpful. There's theoretically the chance that it can allow some healing of the cartilage lesion. I think the jury's still out on that completely, but there are some good braces that can offload areas of your knee. Like if you have a lesion on the inside part of your knee, there's braces that can take the pressure off of that area, which can drastically improve your symptoms. Mm-hmm. So the short answer is no, surgery is not always needed.
Okay. Can knee cartilage issues affect my ability to play sports?
Yeah, obviously it's definitely something that can come up and limit some of the activities you're doing, namely more from a pain or swelling standpoint, as we see. Obviously, some sports are going to be more high demand on your knees, whether it be impact or a lot more running involved. At the same time, not all sports are going to have some issues with cartilage issues, and it's really just kind of patient specific and patient dependent. It can also be the level that you're doing things at and how much intensity. You know, oftentimes people will come in and said, I hadn't played this in years, and I went out with my son or something, and then they started having pain afterwards. So that's a pretty common thing to hear about. I think the biggest thing is just a little bit of trial and error, and just because something bothers you one day, it doesn't necessarily mean to bother the other. And our goal always is try to give you the best options to try to get back to what you want to do and enjoy playing.
Great. And can damaged knee cartilage cause joint damage or arthritis?
Yeah, so arthritis is a term obviously a lot of people use, and it's a broad term. It basically refers to the loss of cartilage in the knee. And in some ways, that's kind of what we're referring to. The arthritis I think most commonly people are thinking about is what we call diffuse arthritis or advanced arthritis. And that's when a lot of parts of the knee joint have lost that smooth covering, meaning not only is it in one contained area that, which is separate from what Dr. O'Connell and I just kind of talked about, where it's more of a contained region, that arthritis is more involved in all parts of the knee. in both underneath the kneecap and the groove and in the weight-bearing areas. And so that damage starts somewhere. And whether it starts with a small lesion and progresses, we do see that happen. But sometimes it can be just general wear and tear over the years leads to just what we call diffuse thinning, meaning it never was a small pothole, but more just a general loss of cartilage over years. And that's due to just the nature of cartilages. Dr. O'Connell talked about that it's not a great blood supply, and over time, it loses its hydration and strength and starts to thin out naturally.
Mm-hmm. We have some questions from Facebook. Are runner's knee and jumper's knee symptoms similar?
Those are kind of generic terms that are sometimes used to describe knee pain. Jumper's knee is more, at least in my practice, more patellar tendonitis type issues. So it's actually where the patellar tendon, which is the tendon that extends your knee, gets inflamed. Whereas runner's knee can sometimes just be more of pain underneath the kneecap or related to functional issues around the anterior knee, so muscle weakness, quad weakness in particular, hamstring tightness, things like that can all cause runner's knee. And like Dr. Vapp said, sometimes people that run a lot don't always focus on other important things like your core strength. So they are similar. They can present with similar pain in the front of your knee, treated very similarly, in that they both respond very well to focused physical therapy and a structured therapy regimen.
Okay. And then our next question is, what are treatment options that are available for patients over age 55?
Yeah, I think there's a lot of great options. Again, I really don't like to use age as an exact cutoff for things. I think a lot of it goes into what your goals are, what your expectations are, what you're trying to get back to, your baseline activity level. And I think once patients are past, on the older spectrum, sometimes it just depends upon the amount of time and energy for recovery, whether it's something that's worthwhile to you from a surgical standpoint, or whether some of those other non-surgical options might be a great fit for you. One of the best things I've seen work very well is some of the brace options, we talk about that can help offload areas for patients, in particular those that want to stay active with certain impact activities, whether it be tennis or running or something like that. And so a lot of that can make a big difference. So, surgery is an option, and there's also a lot of great non-surgical options. And some of these injections can make a big improvement long term or over, time. So I think even once you're over a certain age doesn't mean a lot of those things that we are talking about are off the table for you and can still be very helpful.
Yeah, I had mentioned, age 18 to 55 for the osteochondral allograft. Again, that's a loose cutoff. It depends on functional status. There are some 80-year-olds that are more like 40-year-olds and vice versa too. So it definitely doesn't preclude being able to have one of those. Just have to understand that the recovery can be a little bit longer. Now with the procedure that Dr. Vapp was talking about, the Macy, is that there's kind of a hard cutoff for insurance approval for that at 55 as of right now. And that's very expensive if it was going to be done out of pocket. So that's probably one of the biggest limitations to that actual procedure. But there are other options, and like I mentioned, there are some synthetic cartilage grafts that are coming out that can be available and hopefully will be approved for people over 55.
Okay, and our next question is, do overweight patients have to lose a certain amount of weight to have cartilage replaced or be looked at?
Yeah, so there's some technical things, as Robert's referring to, sometimes for insurance purposes or qualification purposes, just to get authorization or approval for that, there are some weight requirements. We also know from some of the outcome studies after these type of procedures that people over a certain BMI don't have great success. And so it's one of those things where it's not necessarily there might be a requirement from the insurance company, but from my perspective, I'm here to help you and give you the best chance to have a great outcome. And so if I'm going to put you through a big surgical procedure or something that, involves me, implanting something in your knee, we want the best chance of success. And so it's kind of a team effort from that standpoint. And so it's not necessarily that we won't do it or can't do it. It's just for your most optimal success. We know patients that have a lower BMI kind of tend to have better results with these types of interventions. And so it's something that we happy to work with on you. I have a couple of patients that, had a weight issue at the beginning. They worked hard at it, and now we're proceeding with the cartilage procedure. And they're very excited about it, and I'm happy to help them with that. But, so it's not necessarily always the requirement necessarily to, especially not coming to get seen. We're happy to evaluate you and talk to you and go through everything and give you all the options. But, it's sometimes in combination with everything we're doing, it's going to give you the best chance of having a great outcome.
Okay, I think that's all our questions tonight. So thank you, Dr. O'Connell, Dr. Vapp. It was a pleasure having you join us for this discussion. For more information about orthopedics, follow VCU Health on Facebook and visit vcuhealth.org. Once again, thank you, Dr. O'Connell, Dr. Vapp, and everyone who joined us today. Have a great night.
Thank you.
Thank you.